So, we spoke a lot about microsurgery and ergonomics in the past episodes. And I think it's time to move to something else, to another nightmare. And since I want to be nice with my favorite Egyptian, I think it would be nice to address your nightmare, Ahmed.
Calcification, I really hate them. Ladies and gentlemen, welcome to episode number 13 of Endocast, hosted by Francesca Cheruti.
And by Ahmed Shauki. None of us likes calcifications. I mean, they can make our life extremely harder, and really they can turn a treatment into a nightmare. But today we are lucky since a real expert in the field was so kind to accept our invitation.
Yeah, I'm really curious to see which tips and tricks he is going to share. Please welcome Dr. Omar Ikram to Endocast. Dr. Omar was born in New Zealand. Then he worked in New Zealand and UK. He got his MCLIN then and MRD at King's College London. He is a very skilled clinician, of course. All of us know him, and an international educator, co-founder of EndoPrep app, and we will talk about that, of course, and fellow of Pierre Fauchard Academy. He's currently practicing in specialist endo crow's nest in Sydney's North Shore in Australia. Hi, Dr. Omar.
Hey, thanks for inviting me on the Endocast. It's a great honor to be invited along and speak to you guys.
We are so happy to have you. And so, Omar, since we are addressing the topic of calcification, would you like to tell us something about them, some definition?
Well, I mean, calcification is actually something that we're actually, um, unfortunately, well, it's a positive and it's a negative. Obviously, when we get dentine bridge formation, this is part of what we want: healing, covering of the pulp, and our restorative dentistry can survive for long periods because of calcification. Unfortunately, when it doesn't work completely, we end up with bacterial infiltration of the root canal, which has become calcified previously as the microbes try and get into the root canal. The pulp calcifies, and unfortunately, sometimes the bacteria win the race. And then we have a very narrow root canal, which is now infected. And this is the challenge for us in endodontics to be able to locate and then negotiate these root canals, because if we can't, then the patient can get continued bacteria within the root canals and also apical periodontitis and abscess formation as a result of this uh, lack of being able to locate the calcified canal. And as I mentioned previously, if you can't locate and negotiate the calcified canal, sometimes the next step is a surgery or even maybe extraction in some extreme cases. So calcifications are, when we see the patient, often a problem. Although in some trauma cases, when we see it happening and there's a healthy pulp that causing calcification and we don't end up with apical periodontitis or infection, this is a positive thing that we're looking for.
Yes, I totally agree. And I think going into the management, to find the root canal openings, we can rely on some of the basics or classic rules, don't we?
Yeah, I mean, the one thing that I look at is the dentine map. That's the one in the Krasner and Rankow study, which was the sort of classic paper where they basically sectioned teeth and looked at the sort of rules for locating root canals and also the laws of centrality, concentricity, and also the law of the CEJ. So essentially, to me, this is talking all about that dentine map and change of color that we get at the CEJ. And so this is in the slide here, you can see there's a dark sort of dentine compared to the periphery, which is more yellow. And these are the mesial canals down the bottom and a lower molar and the distal canal at the top there. And you can sort of keep going down the route and you'll find the calcified canal eventually if you keep following this path. So as I've gained more experience, what I've realized is that it's not only the ability to see the root canals. This harps back to the old days when I was at King's College and I remember when I finished my MClin dent, I was very proud of myself, and I was speaking to a general dentist who said, "But if I do some reading and use a microscope, aren't I just as good as you are?" And I turned to my tutor and said, "What do you think about this?" And he said, "Look, you've just because you have a Ferrari doesn't make you a Formula One driver." And I thought to myself, "You're right, because the microscope is one thing, but being able to use it properly." When I talk about the microscope, I usually talk about cars because people understand cars. It's like, yes, you can have a really great car, but the first time you use it, you sort of drive it to the shops and back, and then you might use some of the features. But it's not until you've been using it a long time where you can really use the features and park the car better and drive safer, and you just realize the uh, extent of what you have available to you. And I guess the same for smartphones. We don't use all the features, and then we get used to them, and we use more and more and more. So the same thing with the microscope. You use it. It's all about experience and being able to visualize that dentine map, and then being able to see the color change. And now I'll access cases and quite confidently find that dentine map more often than not. Whereas maybe 10, 15 years ago, it wasn't quite the same as that. It has a way. It has something to do with the way our brain processes information. It's essentially you start what we call in the deliberate mode, and you're looking for the dentine map, and you're looking for color, and you're looking for that change, and then you're looking at the periphery and going, no, don't go there, go the color, and that starts this process. We have this deliberate mode, and that burns up a lot of our brain energy. And of course, we finish a day and we're totally exhausted. But as you get more experience, that becomes more of what we call automatic mode. So you open up a case and you're automatically looking for the color change. You're not thinking about it too much. You're just doing it. And then so we don't burn up as much energy. Therefore, when you get more experience, of course, then you can treat patients quicker and easily, and you finish the day and you're less exhausted. That's how I find it anyway.
Exactly, I completely agree, and thank you for sharing this with us. So, of course, as a specialist, you see teeth that others maybe try to manage without having the experience or the tools to complete the root canal treatment. So, can you give us some example of these cases?
Yes, well, here's an interesting case here. The patient had asymptomatic apical periodontitis when I saw them, but they'd had a symptomatic apical periodontitis, and you can see there's some kind of dens evaginatus here, where basically the calcification has started, but unfortunately, like as I mentioned at the start, the bacteria have now infiltrated the calcified canal and won the race to the root canal, and now we have a narrow root canal with an infection within the root canal causing apical periodontitis. So the dentist had actually opened up the tooth. This is the preoperative now. They've opened up the tooth. You can see, and they're looking for the root canal. Unfortunately, they can't locate it. So this is the radiograph the general dentist sent to me, and then they wanted me to treat this case. So what I actually did here was straight up took a CBCT scan of the patient, because I suspect that the canal is probably lingual to where they're accessed, because we know with experience this is probably the case. We've done our fair share of difficult cases where we know the canal is quite lingual. And when you take a CBCT, it automatically will just show where they are in relation. You can see here they haven't perforated, but they've been quite close to it. There's good bone on the buccal aspect and the sagittal section there. And basically, you can see again in the coronal section the apical lesion, and in the axial slice you can see they're very buccal to the middle of the root. So now we know that our hunch is correct. And the great thing about CBCT in this case is we don't need to go get the patient in and then work it out. And again, that goes back to my original concept about deliberate and automatic modes in our brain. It's like if you have to get a patient in and then open up the tooth and work it out on the spot, you're really, really, really using that deliberate mode. You're sitting there going, well, is it this way and that way? And it burns up a lot of energy, and you get tired at the end of the day. So the CBCT eliminates the need to do that. Now I know I just go lingual and I'll find the root canal. So you can see the dentist has had a couple of attempts at finding the root canal, but they're quite buccal. And my access, I found the canal just straight away on the lingual there. So that was quite a lot simpler than it would have been if I tried to work it out. So that was what I was grateful for CBCT in the situation, and I prepared the root canal, 3506 wave one gold medium in this case, which I think is a good one for just straight canals where it's fairly. I forgot patency with some hand files. So that was actually quite a quick case. and I restored the case. It doesn't need a crown; it's occlusal access only. So patient's happy, and that was a straightforward case for me using the technology. The technology is there to, as I said, reduce the amount of brain work we have to do every case. As I mentioned before, if you're doing brain work every single case, every single time, you probably remember the days like I do when local anesthetic required a lot of thought process, and then the dam another bit, and at the end of the day, you just went home really tired. So the technology allows us to focus on other things that are maybe more important than that. There might be something about a case that's more tricky to work out, and we can totally forget about. There's the canal lingual or buccal in this case. We know it's lingual to where the dentist went, and we can move on and do other and concentrate on other things.
Well, that's a very nice case and illustrative and highlight the problems that we might face. But in anterior teeth, we can also have different problems. What do you think about that?
Sure. I mean, we all know about anterior teeth being difficult ones for a number of reasons. First of all, the trauma causing calcification, and then obviously if the pulp doesn't calcify enough, we end up with an infection, and then the same sort of problem. But they're very aesthetic teeth. In this case, actually, the patient has been referred to me. The dentist opened up the tooth with no local anesthetic. When they got to 16 millimeters, the patient had some pain and they irrigated, and unfortunately, the patient ended up with a hypochlorite accident here. The patient was then referred to me after this happened, and they'd recovered from that. But there was a couple of things interesting with this radiograph. When I saw this is the preoperative radiograph I took after the patient had recovered from their hypochlorite accident that the general dentist had created. And basically, I was like, hey, I can't see if there's a canal. You can see there's a perforation at about 16 millimeters, as the dentist had mentioned. But you can't really see the root canal because it's superimposed on the perforation in the 2D image, and also the apical disease. Was this the wrong tooth? I really don't know. The patient's now asymptomatic. So Shannon Kings actually said to me, take a 3D scan on the patient, and I remember thinking this is my first ever CBCT case, and I thought, wow, really? And I thought, wow, this is amazing. You've got the CBCT saying the lesion, the patent canal, and the perforation. So now we know again the canal is palatable to the perforation, and it takes our mind away from needing to work all those things out. And we also know it looks fairly repairable. It's not a huge perforation, just a straight burr all the way down. There wasn't much troughing going on there, so that's kind of handy. So yeah, the tooth. What I did here was actually clean out the root canal and also the perforation. For the initial visit, I actually used chlorhexidine as the irrigant because the patient was so worried about another hypochlorite accident, even though I assured them everything would be okay. Then I filled the buccal perforation with MTA. In those days, I would probably use something different now, maybe biodentine or something that doesn't stain as much. But in those days, that's what we were using. And then I placed a gutta perca cone containing calcium hydroxide in the canal just to seal it for the first after the first visit. And then at the second visit, what I did here was isolate again and remove the gutta perca cone. The MTA is now fully set, and just fill up the canal and restore with composite resin. So this is what happened. So the patient was fairly happy with this. I did assure them on the second visit they weren't going to get a hypochlorite accident. They were very happy, and everything went well. And we used sodium hypochlorite on that second appointment just to make sure it was all disinfected as much as possible. So that was a handy a case with MTA. As I said, in these days, I'd probably use something else for that because it's an anterior tooth, and the staining risk is definitely there with MTA.
Yeah, definitely, definitely. And that is a nice result that you had.
Yes, as you can see, it's fairly stable now. Thankfully, the dentist hadn't made too big a perforation. It was very repairable. It's actually superimposed by the root canal. You can't really see it there.
But we have to be frank. Sometimes the tools that we have can make the difference in some cases because if I can see it, I can treat it, and we know all the things about microscope. But I know that you have made some modifications to your microscope. So can you tell us something about this?
Yeah, so I mean, I definitely think microscope endodontics gives you a lot more than just finding canals. I mean, initially I thought, I'll find canals, see canals better, and sure, that's part of it. But It allows you to maintain your posture, which is a big advantage. Again, it's like that car analogy. You drive, to the shops and back, you don't notice anything. You drive for 4 hours and then you start to feel like your back is hurting, and so you need those extra features on your microscope to make your posture better and your working day easier, because we work long days in endo. I mean, I work 4 or 5 days a week, and I'm usually 6, 7 hours working on patients, and mostly um, the posture will affect you after a while if you're not in a good position. So I definitely find that is a big help. The restorative part of endo is helped a lot by microscopy as well. Being able to see micro leakage under crowns, because in the old days, I remember there was a lot of endodontists before microscopes saying take the crown off and start looking at what's going on there. But if the patient had the crown done 2 weeks ago, it's not ideal to have to take the crown off and they need a new crown again. So now this advantage that we can look through the axis and find the micro leakage, and then perhaps follow the micro leakage and then assess a bit more of whether they need a new crown or whether the existing crown is adequate, really helpful. So yeah, I definitely find microscopes offer us a lot more than just finding canals, but that's obviously a big part of what they offer us. And I think that when you're using microscopes, you want to always get one that you think is going to be good, and then you go one model up. It's same as a car. You never buy the car that you want. You always go the one up, because in about 6 months' time, you'll think to yourself, "I wish I had got the next one up," and then that's purchasing a whole new car. So you're better off to just jump a model, in my opinion. Um, in this situation, I have a Mora interface. You can see, you can angle the head of the microscope 25 degrees, and you can still look straight ahead, and the patient's to the left of me. So this is another good advantage, I find. And this is how you don't look down a microscope. So this is the idea. So the thing I'm trying to illustrate here with this microscope is that if you have a variofocus thickness of around 400 millimeters, um, that is quite good, because what that means is if the patient's out of focus by 400 millimeters or so, under 400 millimeters, you can focus the image of or the tooth of the patient without needing to move the chair. So I've used microscopes where the variofocus is about, or the varioscope they call it sometimes, is around 200 millimeters. And the big problem there is you start on Monday morning, you're all lined up, you bring the microscope into position, and then you focus everything, including the chair movement, and then the next patient comes in. It's a different patient, different arch, different positioning, and you position that a little bit, and then after about 4 or 5 patients during the week, you think to yourself, I can't be bothered doing this anymore. And you pull the scope down to focus it. And as soon as you pull the scope down to focus it, which is very quick and easy, not moving the chair, you drop your head. And when you drop your head, you're in that position the whole day. And that's where the posture problems happen. It's something that happens over a period of time. It's not something that happens straight away. As I said, it's like driving a car that isn't equipped for comfort. You drive it a short distance, fine. If you're driving for 4 hours, you will feel the difference at the end of that 4 hours.
Yes, that's really informative about the positioning and microscopes. And I know you talked about single canal premolar and incisors, and you said that microscopes are not only for finding canals, but also we have to say that incisors are really tricky, with some more surprises for the endodontist. What about missed anatomy?
Well, missed anatomy is such a big part of what we do in endodontics. I mean, as a specialist, lower incisors, you can see here, this is a classic kind of problem, isn't it? About 40% of lower incisors have two canals. Uh, with this case, the patient has had the buccal canal filled, and again, the CBCT is almost always I take a CBCT now on lower incisors. That would be one of the teeth where I definitely just take it straight away, because in this case, you can see there is a lingual canal that's been not treated. And before I was planning the case, actually I do a lot of planning in the evenings for these cases. So I sat down in my room the night before I treated the patient. I thought, what am I going to do? I'm going to remove everything. I'm going to find the lingual foot. I thought, no, no, the dentist has obturated the buccal canal. That's helping me not fall into the buccal canal. Utilize the fact they've filled that and closed it off, and then find the lingual canal first. Do the full prep, then remove the GP of the buccal canal, and then treat the buccal canal. So I thought, but it gives you that again, that ability on the CBCT to say we can plan this heaps better, and it'll be much easier for us, more efficient, and the patient will probably have a much better experience. If I know straight away there's two canals, I can just identify it quite early on the slice there. So you know you're going to find that as soon as you get into the root canal. So you probably got the clinical pictures there. It'll show that they actually, yeah. So you can see there's the previously treated buccal canals of the GP, and I found the lingual canal. I prepped the lingual canal first, then removed all the GP and the buccal, prepared the buccal canal. And you can see there it's sort of a figure eight shape, but there's two root canals there, and you'll see the post-op in a minute um, of me having filled the canal. So there you go. So there's like the figure eight shape, and the canals separate there, the two separate canals. So this is common in incisor teeth, and lower incisors are like the worst teeth to treat. There's a couple of reasons for that. I talk about this quite a bit. Number one is they're right in front of the patient's mouth, and that's always a difficult thing when you're dealing with the most aesthetic tooth. It's not quite the upper teeth, but it's pretty close to uh, being very visible. The other problem is they are small, so you don't have room for troughing around like you do in, say, an upper molar, where you can have a trough for MB2 and look around and work things out. You don't have any working out space. The other one is they're commonly calcified because of trauma or even periodontal disease. Those patients in their sort of 70s and 80s, where you look at it and think, how am I going to find this canal? And basically, the other big problem that I find is that if you can't successfully treat these teeth, placing an implant or restorative options here are extremely limited. There's often crowding. There's often difficulty in recreating that triangular crown shape, especially for implants. And it's just one big difficulty with lower incisors. So I tend to find lower incisors every time I see them. I think, oh no, I've got a lower incisor coming in. I think I'd rather an upper first molar than a lower incisor most of the time. But in this case, I was managing to manage to get a good result on it.
Now, we want to steal some secrets from you. So, would you like to share some of the tricks that you use to locate calcified canals?
Yeah, well, my favorite way is to create a white dot using a slow speed round burr. I know that some people like ultrasonics. Ultrasonics are quite good as well if you've got access problems, because for using a slow speed round burr, we have to actually trough, and we need space to do that. With an ultrasonic, you've got less. You haven't got the handpiece issues. So yes, I'll trough in the dentine map there. You can see the dark dentine, which was the same image from the first few slides. So I'll trough across and create a white dot. And then when you see that little white dot come up, what I actually find now is that you have a white dot. I use an LN burr in this case, or you can use like a slow speed round burr. Obviously, gooseneck is a bit better, so you can see as you drill. I like the orifice opener, but you can use orifice openers. You can even use C plus files, or you can use calcified canal hand files to open up the coronal. But I really like the idea of creating a white dot, and what you sometimes see is, as you're following the white dot, what you'll see is a little puff of like fluid in the microscope, and then you know you're there. And sometimes I'll chase an MP2 and I'll be chasing it down, and then all of a sudden you see the puff of fluid, and you go, "Oh, thankfully that's now going to be found." But you can see here I'm troughing in the distal root of this lower molar, the LN burr, and I'm just looking for that. There it is, the white dot coming up, and then I'll probe it with a DG16. You can use a micro opener. I use them sometimes as well. A file on a stick is another way to describe those. There's a file just on a basically on a stick that means you've got more tactile control, placement, dexterity with that, rather than using a file, and then obviously as you put the file in, you cover up the visualization. So there's a DG16, and then you just open up the canal using the XA orifice opener. You can use other files to do this. I often use the shaping file that I'll be using as well. That's the other option. If I think, oh, I don't want to use the orifice opener because I don't need to, and I'm going to use a shaper later to save on stock, you can always just use a shaping file and then obviously go back to the hand file, use the shaper later in the procedure.
So our famous missed anatomy is the second mesiobuccal canal in maxillary molars, and I know that your app that we mentioned in the beginning has a specific function to help the clinician to locate it. Can you tell us more about the app and this feature in particular?
Yeah, sure. So thanks for mentioning the app because it was quite a project. It first started off way back when William was designing an app on difficulty assessment for AAE, and then I said to him, "Look, I want to be involved in making an app with you," and he said, "Okay, so what do you want to talk about?" And the answer was we were originally going to start talking about preparing root canals, and that's why it's called Endo Prep App. And then what we went from preparing root canals, we went to other things like measuring tools. So this is a free app to download, and one of the things I was doing one day was obviously troughing for an MB2, and I thought we could always get a feature where someone takes an image of the MB1, DB, and palatal, and just use that algorithm that we all use from the it's a Coolidge and Peters paper where they're looking at the position of the MB2, and so we're essentially using that same algorithm. You just put the circles from the app over the canals. Once you've located them, it'll tell you approximately where the MB2 is. You can see the MB2 is just uh, basically below where the MB2 is showing it should be present on the app. So it just helps. There's a couple of things it does. The intention of the app was never to make a dentist into an expert of endodontics that they can do everything and say, you know, I, I, I'm going to use it to treat every case. The idea is actually just to empower them to look a little bit where the app will say it is, and if you don't find it, you need to refer. It gives you that kind of backing that you have tried, looked in some place that might be relevant. It's a bit like the idea of it's probably a little bit like a sort of early AI, where it's like it's kind of like having an endodontist with you and saying, "Have you looked here?" And if the answer is "Yeah, I have," and it's not there, then you need to refer. So we've always had that opinion about the app that the idea is to give them an idea, like as if you would be tutoring in a dental hospital and saying, "Have you looked there? Have you done that?" And if the answer is they've done all the right stuff, and that, then they need to just refer the case off. And that's we've always said that's the idea of it to get the patient. Then you've got another check for the patient to say, "Look, the practitioner has tried. They've looked in the right place. They still can't find it. You need to go and see someone who's a bit more of an expert." And this is the case. Yeah, this is the case here with the MB2. And then if it's filled on the next slide, you'll see it's been filled up.
I think it's extremely useful, and I know a couple of students of mine that would be extremely happy to have this app in their practice.
I agree.
Well, the interesting thing about AI now is that the smaller little things like our app and obviously the small companies can create very quickly these concepts, and then they're like all technological things now. You can put them out there, and then you can change them as you find things that you want to improve on. So it's a very easy thing to do. It's much harder if you're trying to create the world's greatest technology because that takes a long time, and it also means that maybe other people catch up with that and find out about it, and then create their own version. So this is the problem I think we're dealing with a lot, and so I thought this was quite a nice little tool, which was very simple. And William actually was the one who said, "Oh yes, we could do like a kite." Called it a kite tool or kite diagram, and I thought that sounds about right. And I remember after this tool was created, I actually sat in the cinema, and my kids were at a movie, and I was not watching the movie. I was downloading as many images of MB2s on Google I could, and using the app to try and find if the MB2 matched where it did on where it's the app was saying it was. So that was kind of a bit of fun. I sort of was matching it quite a lot of the time, and I thought this is going to be quite good.
And now we located the canal and we need some tricks to know how to negotiate them.
That's correct. So this is actually part of the hard part. You can use these C pilot files I use, or K files are what these are based on. They're essentially just stiffened stainless steel K files, the C pilot file, and you use them with a balanced force technique. So uh, watch wine, pull. Is this exactly the same as you would use a K file? There's a couple of important differences. Firstly, there's a size 12 C pilot file, so you can get that. Uh, and also, they are just, you have to be a bit careful winding back and forth when the canal is very narrow. You do have to flare that canal a little bit so they don't bind, because if they're being stiffened, what means is that they basically rigid. And it's a bit like you don't want to, one thing you don't want to have. In an earthquake is a rigid building because it will fall down. It's the same with our files. We need flexibility, and if it's a stiffened K file, then you need that freedom for it to move. Otherwise, it becomes bound, and it just work. You work hard on the file as you watch wine. So that's something to watch out for with all stiffened files. The other files that I use are the C plus files, which are basically stiffened stainless steel, but they're variably tapered. They also have a cutting tip, so I don't use those at the start. Well, I use them at the start just to get the orifice open sometimes, or at the end if I'm really desperate. You can see there's a variable taper. I like this. The patency filing technique I came up with during COVID was an interesting one. You've probably seen it on social media on Instagram. Basically, the idea was we were getting. I used a lot of C pilot files, and then all of a sudden they were out of stock, and I was using C plus files. And I sat down one evening and I thought to myself, I wonder why the sizes are the way they are. With the size 6 has a 5% taper for the first 4 millimeters, the size 8 has a 4.5% taper, and the size 10 a 4% taper. And I was thinking to myself, why have they made the files those sizes? And I thought, hey, if you poke the 6 through the end by a millimeter, then you don't have to use a size 10 because the apex is now an 11. The size 8 is you're halfway to the 15 if you poke that 1 millimeter through the apex. And all of a sudden I thought, oh, those distal curvatures you get in lower molars, now I can manage them using these files because you can often get the 6 down or maybe the 8, but then if you try to pick up the 10, then it's another job and the 15 doesn't go and it creates a ledge there. So all of a sudden I was picking up the size 6 and just pushing it through by a millimeter, and then I was basically doing the work of two files with one. So then I started using this more. Obviously, you do have to watch for areas where you can't patency file near the mental foramen or those areas like that. So you have to be careful. But if you're in an area where there's not those problems, then it's a good technique to be able to use. And they're used in a different way. So they are used with a quarter turn pull. So just push and then turn a quarter turn and then remove. Just pull straight out. So in this video, you'll see me winding, not watch winding, because watch winding, what happens if you watch winding, there's a couple of issues. Firstly, they're stiffened files. So as I mentioned before, that's not very good if you're winding them back and forth. Also, they are variably tapered, so they lock in the canal in the first 4 millimeters. So the first 4 millimeters have greater taper. And also, they have a semi active tip, so there's a tip that will bind, and if the tip is binding, then it's locking even more into the root canal. And if you watch one back and forth, all that's going to happen is the tip will come off. There'll be you'll exceed the torsional failure, and you'll end up with a torsional fracture. So a lot of people have said that has happened to them using these files, but I haven't found, since I've been using this quarter turn pull technique, that I've had any issues. So it's all in the technique. And again, this is just part of the experience and being an endodontist, and knowing that these files are different and you use them differently. You can accomplish a lot once you get really good at using these hand files, especially for calcified canals, because as I mentioned before, with the variable taper or the greater taper in the first 4 millimeters, if you can get the 8 down and then you can push that through by a millimeter, then you can pretty much go straight to the first rotary file. You don't need to pick up the 10 and the 15. Once you've got an apex that's 12.5, that's in my book, that's straight to rotary.
Well, that's very specific tips and tricks, and you said them in a very appealing and interesting way. So we thank you very much, Omar, for sharing your knowledge, as I said, in a very simple and appealing way, as always, of course. And I would like to have something to ask you, but I'm afraid that we are a bit short of time.
I know what you want to ask, Ahmed, but I think it's episode 14 material if Omar will be so kind to spend some more time with us.
I'll definitely be keen to come back. Sure, we can probably talk about some CBCT or some other topics that you guys were interested in talking about for sure.
Okay, thank you for that because that would be interesting as well. And after calcified canals being a bit less terrifying now after this endocast, so what do you think?
I do 100% agree. So thank you, Omar. It was very, very nice to have you, and it was an honor for us.
Oh, thanks so much for inviting me, and it's a pleasure to speak to you guys today. I hope you guys have a great weekend. I've got work in a few hours, so I'm going to be back to the tools.
Yeah. So thank you again, Omar. Thanks, my co-host Francesca. Guys, stay tuned for the next episode of Endocast. Ciao.